Welcome. This is incredibly exciting. This is our kickoff inaugural online event. So I absolve ourselves of any responsibility if there are technical glitches. We're not responsible, and the show will go on regardless. So I have a very exciting guest today, um, who is the first in this series where we're introducing the leadership for Genesis Medicus Clinical Campus, and also someone who is a seasoned physician. Dr. John Kowalczyk is with us, and I'm going to take a breath, but try and get through it fast because his body of work is insane and wonderful at the same time. He's a board certified urologist, which to medical students out there is also a urologic surgeon. He is in the Southern California region. He's an expert reviewer for the medical board in California, former president of the Osteopathic Physicians and Surgeons of California. He's a clinical professor of surgery at Touro and Western universities, a California delegate and former council member on osteopathic postdoc training institutions, and for the American Osteopathic Association. He's medical education director of and clinical clerkship director of surgery for SABA, St. George's University School of Medicine, MUA, Trinity, and ACSOM. He's been on the board of directors of Good Samaritan IPA and Physician Aid Association, a co-editor of California DO magazine. His current hospital privileges, I think, amount to about 8 or 9 hospitals, including PIH Good Samaritan Hospital Medical Center. In the past, among many hospitals, he's been affiliated as Cedars-Sinai. He's chairman of the Good Samaritan Hospital Patient Safety Committee, been chairman of the Department of Urology and multiple committees. He's on the Medical Executive Committee and peer review committees. He's had multiple publications affiliated with the American Institute of Research. He has been named Physician of the Year, Physician Editor of the Educator of the Year. I could go on, but actually I'm going to leave it with the fun facts. So if any medical students out there, ask them about horse breeding, being a lifetime member of the Eagle Scout. Those were particularly important to me. And the other that was so interesting was he is certified in open water and deep water diving. And I had the luxury of spending the day a few years back at the White House Medical Unit, where I got to spend the day with the physician to the president who did extreme diving. And I encouraged, it's the physiology of diving physiology, aviation physiology for medical students is so fascinating. Read about it, and we'll do a didactic on all of those different unique physiology platforms. But welcome, Dr. Kowalczyk. Thank you so much for being here. I want to jump in, as 8 years of Latin, 3 years of ancient Greek, Genesis Medicus, actually, Genesis could be origin, birth, medicus, healer, doctor, physician. So I'd like to start with your origin story. Start with a 30,000-foot view, and then we'll pivot ultimately to the 30-foot view for medical students on what they should have for their expectations of clerkships and the like. So I'd love to know, what drove you to medicine? What prompted, was it intentional or happenstance? What factors along the way, if you can also outline what's required to become a urologic surgeon for those not in the know, and brought you to this day in terms of that?
I'll give a short synopsis on that part because medicine, unlike many other medical students, medicine was not on the forefront of what I wanted to do. I was a chem major. I loved chemistry. I just decided to take the MCAT one day. I did well on that. I applied to 4 medical schools. My sister's fiance at the time was this amazing cardiologist at Loyola University Medical Center, way beyond the days of HIPAA. Got to do rounds with them on weekends, spend the weekends with them. Next thing I know, I'm applying to the same schools. Well, I applied to only 4 schools. And one of the schools I applied to was basically the same one that he went to because I wanted to be a cardiologist just like him until I got in. And then once getting into medical school, I had what we call cardiac physiology, hated it. We became mortal enemies. Didn't know what else to do at that point. Started going around in my rotations. I'm sure every other student's doing about the same thing. Fell in love with surgery. Back in the day, this is 30 years ago plus, guys. So back in the day, we didn't have cell phones. We had pagers. Nowadays, pagers just means that you might be a drug addict, a dealer or something. But back then, it meant you were in medicine. Payphones everywhere. That's what our lives were like. And I got a beeper from the cardiovascular surgeon I got put onto that one time. And it was the most amazing experience of my life. I volunteered every time when he got called to come in, and boy, was he busy at night. And at that time also, we had a lot of hands-on, especially in Chicago with like the Cook County Hospital, et cetera. If you get affiliated to a county hospital, guys, take it. The experience is unbelievable. You get over the fear factor, you get over the shock right away. You'll learn so much, and that's how this all started. Then next thing you know, I'm in a residency program. Started out in trauma. After 3 years of that, I kind of burnt out. Back then in the day, we didn't have, if you recall, we didn't have hours that were restricted to the amount of time a resident or student can work.
Familiar with those days.
Yeah, so my first 3 years were 36 on, 12 off, 2 weekends a month off, and 2 weeks a year vacation. That was my first 3 years. A urology spot, and also ACGME with the match. That was not exactly that popular when I was a medical student. So we got to go direct and interview and sign contracts direct. And that's exactly how I got into urology. Urology is a urologic surgical specialty. Average time is anywhere, in terms of residency time, is around 6 years. I went off and did an extra fellowship at Indiana University. So my postgraduate training is 7 years, and came out to California. What I failed to mention is I started medical school at age 19. So by the age of 30, I already was fully board certified. By the age of 31, I owned my first practice, and here I am today. This will be 30 years later.
Well, a bunch of things that you bring up certainly resonate. I started my first residency in neurosurgery at Downstate, which is Kings County Hospital and the like, and I highly recommend. You have an ability I did ventriculostomies in my intern year and things, ultimately switched fields, which is another point that you bring up, is that your story is wonderful and inspiring, but it doesn't have to be every single person's story. Everybody's path is different, and you can do so many different things. Did you fall into going into researching and leadership and all of these other things, or were those passions?
Absolutely. Falling in is a great way to describe it. All of a sudden, one day, this little institute down on the floor beneath me comes up and says, "Hey, we have this really cool. We've been invited to join this really cool research project." And it all started with a testicular implant. If you recall, in the day when before, Downey used to make these silicone-filled breast implants and testicular implants, and then we had this big silicone ban and recall and all that kind of stuff. So one of the companies came up with a non-silicone filled testicular implant. And that was my first clinical study that I was involved in. After that, I got involved in several others, including Cialis, and I'm actually published for Eli Lilly as one of their investigators. And so that was with the use of Cialis in BPH. So these are the things that can occur if you get yourself in the right place at the right time. You can get research, you could get publications, and then you just get more and more research. And that's where we're at today with that side.
It sounds like the origin of that for you was starting with your passion. You hooked on to what your passion was, what you were spending so much time doing, couldn't get enough, and the other things came along the way on the path. And I think that kind of resonates everywhere. Shifting gears to, why don't you discuss what your role is with regard to Genesis Medicus and how the preceptor model you find, because you, according, I have quotes about you: outstanding surgeon and engaging educator. Your energy and hands-on leadership for simulation training and didactic lectures make a lasting impact on learners. So talk to me about what that means to you to educate the next generation, and specifically what this model of precepting and your involvement with Genesis has been.
Sure. So universally, although I'm an osteopath by training, and my board certification, I sat on the American Osteopathic Association educational committees. One of the things that our motto is that the students, the youth, you are our future. So if you want to, and the way we joked about it when we were in committee is, if you were going to be my doctor when I retire, what do I want to help mold or shape or form? And that's how I got started. This is the type of doctor I would like taking care of me when that time comes. And in terms of getting involved in Genesis, oh my God, that's a fun story, because one of my dear friends, I've been involved in educating students on and off in clinical preceptorships. And one of my colleagues, who's still with Genesis, is a general surgeon, comes up to me one day we were in a surgery center on a Saturday. Yes, Saturday. And we were doing our elective cases. Yes, elective cases on a Saturday. And he he basically comes up to me and says, hey, look, we have some students that need some places to rotate. I started out just kind of as a little ad hoc member of that. Next thing I know, I'm asked to take on some of the teaching components and giving lectures. And I love to lecture. That's one of the things I really love to do. I am not your very traditional lecturer. I use a lot of street language, and I use a lot of real basic descriptions. Yes, yes, those of you on here, you do need to know the language. You need our terminology. But to help you pass your exams, to help you communicate with your patients, I'm going to use things that are in your kitchen, that are on the street, to help you describe what's going on physiologically, anatomically, etc. And that's how the education started. And then in terms of the Zoom, well, that wasn't me. That was COVID. We were in a shutdown situation. Our poor students couldn't get hands on. And I feel so bad for that generation. But I think many of them have been able to survive and thrive after that. But we got together on Zoom and we had meetings almost several times a week just to go ahead and make sure you guys understood what you needed to know and give. We had to be creative as to what kind of an imaginary patient we can provide. And I think part of it is also everyone has some sort of a creative part in their brain. Mine is I'm actually a magician member to a club called the Magic Castle here in the Los Angeles area. So that's my creative side of things, trying to put together some imaginary person, imaginary patient as we went through the whole process.
Well, you're speaking to the choir with respect to the being such a proponent of effective communication. That's always been my mantra, having tutored my whole life, I'm a huge believer that there's so much lost innovation at the interdisciplinary knowledge gaps. And if you can't effectively communicate to patients, you can't assuage suffering. If you can't communicate to those, if you're passionate about researching something, but you can't allocate the resources because you can't make people understand what the importance of it is. So I think it's as important to healing as anything else. So that's a wonderful attribute. And I think students should be learning that more and more today. Can you, and also one of the other things that's so interesting is your expertise can be utilized in the implant world, in the medical surgical world. I think what's wonderful is the agility you have to be more medical or surgical at different points with respect to the field of urology. But how, with regard to your field of study, what is the mainstay of your surgical practices these days?
I'm getting older. And so I'm doing less and less of the more advanced surgeries. I'm not trained in robotics, so I do have robotic surgeons. And when he is busy with robots, he's always not, and he's relatively new to our group. And although he's not fully engaged in the educational component when he's doing robotic surgeries, he's always inviting our students to see that. So from my standpoint, we're doing the general urology. We do a lot of what we call bread and butter nowadays, although I have not given up one of the things that I am subspecialized in, and that is gender reassignment surgery. So I rearrange the plumbing, and again, there you go, that's the street language. I rearrange the plumbing below the belly button on patients. We've done well over 500 surgeries in the last 15 years. And I always encourage my students, even if you're going into, especially if you're going into psychiatry, because a lot of these patients have to see a psychiatrist or a therapist before they get approved for surgery. They need to know what these patients are going to go through. And it is not just a life-changing experience, it can be a traumatic experience, especially when they wake up and they realize that they're a very different person for the first few weeks.
Well, you brought up so many different things within your field there that I think it gives a lot of people food for thought. There's oncology within urology. There's all different surgical kinds of components, and you can kind of chart your own path, it seems. I do want to shift to, I think medical students in general want to know, and also when you first start, everyone has good intentions. They're doing their first rotations. They don't know what the expectations are. From your purview, what do you think a student needs to be successful? What are some do's and don'ts with regard to starting a clerkship in surgery in terms of, are there certain expectations to pass for high honors? What kinds of things do you think are important for them to get the best out of their educational experience and really help them be successful?
Absolutely. Good question. And here's the way I approach it. And it's real simple. Everyone can easily pass if you just show up on time, if you read the material, if you prepare yourself, and just be engaged. if you show that not everyone wants to go into surgery, obviously, not everyone wants to do certain aspects of medicine. A lot of people are already focused, or what I say, hell-bent on one particular field. You still need to understand all aspects of medicine, especially if you're going into, for example, internal medicine, family practice, because your job is to make sure that my patient is able to go under anesthesia
Deeply.
and survive and get up. I'm not an internist. As I go like this, and I'm like, let me get my stethoscope. Oh wait, I don't have one. I use a cystoscope.
When
So
I started in the surgical field, they used to whisper, "There she goes again with the stethoscope."
absolutely. I do have a stethoscope because you need it for research, but I leave it on my desk. And the simple part of just passing is be engaged, study the material, and you'll get a passing grade. Honors, these are the students who basically roll up their sleeves and they start functioning as what is I refer to as the sub-intern attitude. After the first week, if you really have paid attention to what my EMR is doing, to my routine, right now I have a group of students that they're on their last week of rotation. I can honestly be late I've had meetings during lunchtime and the meetings have gone over. And I was able to tell the students, all right, I'm going to be a few minutes late, get the patient started. And they already know the routine on some of the basic stuff. Now, these guys are probably going to get a high pass because they know what's going on. They've gone in the rooms. Everything was ready. Yesterday was one of those days. Everything was ready when I got back from my meeting in the afternoon session. That's the kind of student that gets those high passes. Honors, I expect a lot more from you. If you want to get honors, I need you to be able to come and tell, even if you don't want to be a urologist, I want you to be able to understand the pathophysiology of what's going on. And here's the basis of where that comes from. Everything you guys learned in your first 2 years, especially in a specialty like mine, the urology component, your pharmacology, your physiology, your anatomy especially, all of it comes into play. So if you think you're going to forget all of that stuff, well, not on my service, you're not, because just like in neurosurgery, all of that comes into play, and it's not something that gets to be put aside or put under the rug or you dust off the shelf later on. It's in play every day.
Well, I ultimately went into pediatrics and have done other things in educational advocacy, you name it, writing. And I'm a believer that knowledge is cumulative. So you can learn everything and anything. You learn what behaviors you never dream of emulating. You learn behaviors you only could dream of emulating. Dealing with patients, dealing with other colleagues, personalities under high stress. You learn conflict resolution. You watch and learn and keep your eyes open to see the different ways that people diffuse situations. When you're dealing with someone's child, it's the worst day of people's lives. It could be the most joyous. Giving birth could be the happiest place in the hospital. But I think all of those things are so important. Are there particular resources that you would direct students to that are helpful in staying up to date, or with regard to boards or any of that kind of learning that in your field that's the staple or standard that most do well with?
Well, yes, and the good thing is that many of the schools have their own portals for the students to go to, and I basically will refer them to that. We do a Zoom session or a team session, and we go over some of the questions that are on their steps and shelves in order to help them pass these as they go along. And then lastly, not lastly, but in the office, I have a whole bunch of books. For those of you who don't know, books those are basically iPads made out of paper. And so I tell people there are books on my shelves, and my favorite book is called The 5-Minute Urologist. And right there and then it becomes a huge resource. And then the last thing is the American Urologic Association has an app. It's the AUA guidelines. In urology, 85% of what we do is all guidelined. And if you download that, no matter where you go, emergency medicine, family medicine, you will know what you need to make sure your patient gets before they get to see the urologist. Because just as you already know, as a neurosurgeon and as a
Well,
urologic
I didn't
surgeon,
say I started the residency boarded
oh,
in pediatrics, so
well then,
I like to sample the different fields.
under well, but still, as you know, there are so few of us out there, and so many more people out there. Getting in to see us sometimes is a challenge. And once you get, if you can do the basic tests and have them show up with that, you've just saved them 2 extra visits. If you just send a patient to my office with nothing, they have to go get the basics, just like anything else, basics, basics, basics.
Well, I mean, I definitely agree with you with that with medicine. You do it right the first way, and then you prevent a downward trajectory that only makes it more challenging. And that's honestly with anything, with studying, with preparing for different things. What do you think are realistic, wrapping up, what do you think are realistic skills that medical students should expect to acquire from these core clerkships? Where do you think they should be when they start to kind of going through the process? Should they be hard on themselves if they're not at a certain point? Hopefully not. How do we meet the expectations, but also, the goal is to buoy, but also to cultivate resilience, and that balance can be a challenge, I think.
Absolutely, and that is one of the we sometimes our clinic sometimes gets invited, if you want to call it that, to take on some of the students that may not have been wanted or have been asked to leave their other service, and they end up really excelling afterwards. And here's the thing. Part of it is learning empathy towards the patient, but not just the patient, my staff. I want you to see how hard my staff works. If you could see that. And here's the interesting thing. These misfits, if you want to call them, that's what are they? Do you remember that the Island of Misfit Toys or something? It's an old Christmas animation.
Well, I'm ageless, so I won't know. I'm choosing agelessness today. So
So so I'm the one that welcomes those toys that in this case are students that may not have been received well at other places, because I know that if they get exposed to and here's the make or break. If we can change your self attitude, your how you accept yourself and how you accept medicine as it is, and you can leave the rotation feeling good about what you just did, we already know that you'll probably succeed if you can get the rest of that, which is the memorization. Yeah, you got to memorize, sorry. The memorization and the other hands-on. So it's a matter of learning the empathy, but from the standpoint of not just the patient, but the staff, understanding the basic principles of the particular medicine, in this case, urology, surgery, because surgery is universal, wound care, pre-op, post-op, doesn't matter if it's the eye, the toe, the genitals, it doesn't matter.
or
It's
even in
the
the
same thing.
medical fields, you have to know what is surgery and what's the urgency and not delay with respect to that. So they all interrelate in that capacity, I
Cor-
think.
Correct. And here's the other thing is I use other resources, even videos, like there's the House of God, if you remember that. There's a movie of the House. Every student has to watch that movie on my rotation. And part of it is there's an ethics behind it, a morality behind it, and understanding what medicine and sadly really hasn't changed since the movie was made in 1980s to today. Understanding how we approach that kind of field of medicine and realizing it's the practice of medicine. We haven't reached that scientific component that well, and integrating this and doing the best you can, realizing that we're human, we're going to make mistakes. And once we could get that, and if I could put that human aspect in you, if I can light that fire of wanting to be there to take care of the patient the best you can, knowing you're not going to fix everything, you're not going to cure most people, but part of that, and at the end, we see cancer, as you mentioned early in this interview, we see cancer, we see people in their end stage, realizing that as physicians, part of our job is to heal them spiritually, emotionally, and getting their body ready for that last and final breath.
Right. It's a real privilege, and it's very special in a different way than other moments in medicine are special.
Absolutely.
And to your
Absolutely.
entire point, it is really, I'm a huge, use an empathetic lens with everyone, because if you understand where someone comes from, you can help to facilitate their success in that regard. And to your point, people thrive and blossom at different points. And sometimes it is there's some expression of the I never get these right. I murder them. Move the seed. It's not the seed, it's the environment. Then you move the seed where there's light and water and it will grow, something
Yeah.
like that. So there's no perfect course. There were people in my medical school who had a whole other career started at 50. There were people who Did medicine shift it elsewhere? There's no race with regard to it. If you're not alive by some rotations, that's okay. You can find your mix and really, take off at different points. So I think that's certainly a wonderful um, lasting thought. And I guess the final thing I'd ask you is, I know we spoke briefly about the simulation innovation, and where do you think with regard to, because I'm a huge believer in, apprenticeship, really see what, show, don't tell. You really do, as you said, get the basic architecture and infrastructure of the language and that, but how you emblazon it in your mind is by treating that patient. You will never forget that patient who had this particular condition, or that family. Or I just remember the first birth I did. The
Right.
family sent me a card. It was their fourth child. They could have delivered the baby without me, probably. And it was the most spectacular thing I had ever seen ever been a part of in my life. And they, in their thank you note, they said, "We'll never forget how excited you were at the birth of our baby." So what are where do you feel the direction towards the future in medical education? Do we need to reinvent the wheel? Are we, the whole preceptorship, I think, is a fantastic learning by doing model, but with your exposure to these digital didactic abilities and others, is it a hybrid component that you think is the best going into the future? I'll leave you with predicting the future and where we are, where we're doing well, and grade where we are and where we're headed in terms of these things with medical education.
Looking in, doing the magic and creating my mentalism component on all this, I'll leave it at the fact that there will be no replacement for hands-on experience. And the way, and I'll start by saying the way I approach it is, your first day with me is we communicate by text, letting you know how to dress, where to be, and what time. Your first day with me, once I go through a real quick orientation of my EMR, I literally put you in the room to start getting histories on your own. And then I'm going to come in, if you're and I will redo the history in front of you. So you're getting your hands-on exposure immediately on day one. Secondly, while we're in the operating room, especially if it's a situation where there might be a stitch, that because a lot of urology is endo. However, if we are putting stitches in, I'm not even going to ask you. I'm not going to be concerned. I'm just going to put the needle driver in your hand. So I do believe that kind of a hands-on experience, and doing so even without you being ready to do so. And that's and you, that's not the shocker component. That's what real medicine, real life is like. We're always hit with things that are unexpected. And if
Right.
you don't excel, don't worry about it. If you're not going to be a surgeon, I don't care how slow or how smooth your stitching goes. I'm there to support that. I'm there to correct that, and I'm there to show you what to do. And now the simulation part. Well, not everyone is going to be able to get that hands-on exposure in every aspect. Again, we go back to the pandemic that kept people out of the hands-on component. So we're going to need to have that kind of hybrid moving forward, especially with the fact that as we're graduating more students, and you're not going to have the as many preceptors, and that's the challenge, that are willing to take you under their belt. The smaller the class, so to speak, of students with preceptor, the more hands-on each student can get. The bigger that goes, the harder it is for everyone to actually touch every aspect of what we have to offer in that hands-on component. So the simulator is going to be important, and it works. The simulator works in, especially, for example, we're delivering a baby. Well, let's say I want to go into psychiatry. Chances are, unless you're on a plane or unless you're someplace in where you weren't expecting, you won't have to deliver that baby. Although, as you said,
You may have to deal with postpartum psychosis or other issues with
other
regard.
issues,
So,
exactly.
to your original point, it's important to.
It is. And so to see that, even if it's a simulator component, you need to get some sort of experience. And the way I'm going to, the reason why I do find there is a component, I'm also, although I'm not actively flying right now, I'm a pilot. Part of my training, yes. Part of my training was to sit in a simulator, learning how to land the plane and not crash, so that when it finally came for my solo, that I would actually survive my solo flights. And that's where the simulator can come into play. So even if you're going to be a psychiatrist, if you've simulated a delivery, for example, there's a good chance that you will have a better outcome than somebody who's not even seen one before. And that's
Mm.
my view on that hybrid. No, there's no replacing the hands-on. No.
No, no, I think it's we didn't have that when, when I was training, which now will date me. Um, I don't think as a substitute, but they do have sophisticated models now with AI where you can, you know, just getting to used to talking to patients in a way that are uncomfortable. Everybody's personality is different, and you forget how young people are who start. To your point, you were 19. People have different levels of maturity at different ages when they go in. So some of those, they can really do a lot of things with these simulations of create a code for this reason, for this other medical reason, so that when they do go into your point, it's not the first time they've seen it. So I think in that regard, as an adjunct, but not a replacement. I don't think there's ever replacement for seeing a patient, touching being one-on-one in the room, and we could do a whole other one on all of the third-party access that have ballooned and put distance between, which I am not an advocate of for the greatest quality care for patients. But I'm in awe of the pilot thing because that's my one fear. I won't let it stop me from living, but I literally do believe that I taught myself the physics of lift. I've done everything to try and I'm good now, but I don't love it. I just, face that. So I'm totally inspired by that magic
May,
that you
may I
do.
give you the reason why I took flying is because I had been in two near.
Oh,
One was a commercial landing that didn't go well. There were some more fatalities, a tail of a wing crack, and I was afraid of flying, and that's how I overcame my fear.
wow.
That's also the reason I took up deep water diving, and I'm a shark diver, a certified shark diver in two countries, Australia and the United States, because when Jaws came out, I was afraid of sharks.
Well, Jaws, I mean,
I
Jaws
was
is
8 years
a
old.
classic. Everyone from here want to, distract yourself to something else to Jaws, but you have that in you. Like I could go speak in front of a crowd I've never heard before in a moment's notice. Some people are panic stricken with regard to that. Me, I'm better on the ground. I was built short to stay closer to the ground. And but no, that's fascinating, and I think that's so wonderful to have a vibrant for your mental health and well-being, and also to understand patients, because the one thing I've seen, fear is universal. It may manifest for me with flying, it may manifest for you in a different way, and we all manage it differently. So, I mean, some medical students are fearful of starting their rotations, and you do it and you rip the band-aid and you go, and then you shift to something else in terms of that. So fear
Correct.
is part of humanity. Every patient feels it. So if you can relate to it and also, kind of exercise your mind like you do when you go to the gym to relieve that anxiety or stress or whatever it is, that's always helpful. I am so appreciative of the time you spent. If there's any final thought you have, I want to respect the magic that you're going to do. Did you like that? With patients today, because Dr. Kowalczyk generously donated his time this morning, and we did have a little tech glitch at the beginning. But I think, but here's another example of these things happen, and you come up with a workaround, and you keep it through. So I'll give you the final um, ending of today, and I
Find the fun. Find the fun in your rotation. Find the fun.
love it. Have a great day. Thank you so much. And hopefully, when I go out to California, I'll get to see you in real time so that we can, underscore the importance of the visual and the digital and the in person.
When
That's
you're
the
here, let's go to the Magic Castle.
okay. I don't know. I'm into it. Let's do it.
All right. Thank you.